Many
Please.
thanks to all the senior faculty members and senior colleagues, Dr. Ratnam and Professor Gupta, and it's wonderful to meet everyone virtually. So my talk is very basic. It's an examination, eye examination in uveitis, what to look for, and I would add how to look for it as well. So basically, when we are examining for uveitis, we should examine the eye as a whole, look at the face as a whole, and see the patient as a whole. We generally tend to see a dilated fundus, see the images, but we should see the complete picture, not only of the eye, but also the face of the patient. It is important to have a dark room, and dark adaptation of the examiner is important. And it may be nice to move the slit lamp next to the switch, because you don't always have a fellow in the room to help you with putting off the light. So we must insist on a dark room examination. Excellent slit lamp with excellent slit lamp techniques go a long way, and the use of undilated examination cannot be overemphasized to look for congestion, anterior chamber feature, and iris features. So here is a patient who is referred to the inflammation clinic, but there are no cells, no synecdoche, no iridoplegia. This is congenital heterochromia, and it is not a post-inflammatory heterochromia. So first of all, we must know whether we are dealing with a uveitis or not. The red-free examination is very helpful to look for scleral congestion, scleral vessels, and this technique is really helpful in delineating the scleral changes. We've already talked about GIA and the band-shaped keratopathy, and the systemic features also need to be seen. It is essential to examine both eyes, not only the eye in which the patient is complaining. Use all magnifications, and you can see the moth-eaten appearance starts initially in the contraction furrows. So the later on it will come to other areas, but it starts in the correct in the areas where the contraction furrows is. And you can actually see them much better with your newer machines, with the infrared and the autofluorescence, giving rise to what we call multimodal imaging of the anterior segment. So this is a patient here who has got a heterochromia. You can see in the contraction furrows, the heterochromia has started, and it is not responding to treatment, and herpes simplex was positive on the PCR. So sometimes when there is an occlusio pupillae, you don't see the cells, and the cells have actually settled down because the aqueous is not having the currents. The moment you break the synecdoche and the aqueous currents start, the cells start to be seen, and that is when you realize that the inflammation is more active than what it was earlier. So do see in all magnifications in a dark room, look for the synecdoche, broken synecdoche, and if it's what happens with higher magnification in a poorer slit lamp is that you lose the resolution. You will not be able to see these cells. But if you have an excellent slit lamp in a dark room, you can actually see, count, and grade all that we have learned earlier in the talks on how to grade these cells. So you require an excellent technique, excellent microscope, and a dark room to see for all these findings. And once the synecdoche break, then the entire picture comes out. You can see you can actually then see the various things in retroillumination as well. You can make out the Descemet's folds, which are not being seen when the undilated pupil. But the moment you get the reflectivity from inside, the cells start to move, and you can see a lot more there. So I don't think we'll have time for the video. We'll go to the next slide and look at the angles very carefully, because that's where the stasis occurs. So it may be looking as a not a beautifully done surgery, but that's not the thing. It's actually a granulomatous uveitis, and the only telltale sign is one small nodule here and a pass here. So you don't want to miss that, and then you can put two and two together, and you will see the finer details when you go into our high magnification. You must use all magnifications and take all features. So there is an element of interstitial keratitis, there are the strings of Kapp's nodules, there is a Busaka nodule, and all of these features need to be noted before you come to the final conclusion of your diagnosis. Very often, when you see the anterior chamber reaction, you don't look at the pars plana, but you must make an effort to look beyond what is obviously seen, and you can actually beautifully see and even demonstrate the the exudates over the pars plana with your ultraviolet field, and you know you're not dealing with just an anterior uveitis. This is very obvious. You have got a red glow, and you can see the poliosis and vitiligo, but here you have got a very subtle, very few eyelashes are white, and you should not miss the acne and the hirsutism that is happening on the face. That means the patient for VKH has been overtreated with steroid, and it's time to go on to immunomodulatory treatment. And whenever you have an eye which is injured, it is important to look at the fellow eye even before doing the suturing. Before we are taking up for this patient for repair, we realize that already sympathetic ophthalmia is developed in the other eye, and therefore the management changes. So it's not just looking at the eye that comes to you, but also the eye that has not come to you or presented obviously. And here you can see the exudative retinal detachment is behind the lens. You cannot see anything. In fact, I sent this patient to PGI Chandigarh, and here an anti-tubercular treatment was successful. And you can then see that there is a lot of excavation, and the whole disease has come under control. And it presented as an exudative retinal detachment, but there was an underlying tuberculoma that was the cause of this misdeed. Hypopion can be there with Behçet's, HLA-B27 and leptospira. It is interesting that this patient presented to us after cataract surgery with a hypopion, and therefore it was obviously thought that this is actually a endophthalmitis. But if you look at the eye carefully, you see these sclerosed vessels all over. And when you do the angiogram, you see the furning petal. And then the patient next day complained that he's having pain all over wherever you had put the injection, suspecting pathergy. And therefore, we could demonstrate I wrote his name here, and it became hyperemic, and you know that we are dealing with Behçet's disease just because he complained of the sensitivity after the injection. So another problem with viral uveitis is raised intraocular pressure. There is a complete iris atrophy, not only of the stroma but also of the pigment, and you can do the fluorescein staining to look for the subtle corneal changes. There is an endothelitis, and the pigment gets stuck, and the moment the uveitis comes under control, this pigment will go away and disappear. So for me, corneal opacity with pigment dispersion with atrophy is viral uveitis. So this is a very oft neglected technique, but I would say emphasize that one should examine the cornea very nicely. The video is not coming up, but it shows that and you should use the gloves now. We started using the glove, but we should use the glove more often when you are dealing with herpetic disease, so that you can pick up the acute retinal necrosis and treat it in time. So can I take one more minute, Dr. Balla?
Please.
Okay, so this is a patient who came with severe vitritis. One could not see anything to make a clue, but careful examination showed transillumination and irregular pupil, and we knew we are dealing with an acute retinal necrosis. So pitfalls and challenges. This was actually looking like cells, but this was ghost cells. There was vitreous hemorrhage, and this patient was treated with Tricot injection erroneously. Actually, it was a case of ghost cell glaucoma. Then this was a patient which had a orangish glow, and this was actually a pheochromocytoma with bilateral exudative retinal detachment, which I treated on multiple occasions at VKH because I was not looking at all the finer points. But once the patient came in acute crisis, hypertensive crisis, and a correct diagnosis was made. And a retinoblastoma, of course, can masquerade, and everything that's red is not uveitis. There could be medicamentosa. It may not really be uveitis. So you must look for the masquerade, look whether it is just anterior uveitis or the tip of the iceberg of a panuveitis. A thorough examination, complete correct interpretation, tailored investigations are very helpful. Thank you so much for